All right, so it is my pleasure as one of the epidemiology co-chairs to introduce our plenary speaker, Dr. Isaac Luginaah. He's the Canada Research Chair in Health Geography, a distinguished university professor at Western University, which is also my university, and co-director of Western Centre for Climate Change, Sustainable Livelihoods and Health. Dr. Luginaah is well known for his mentorship at Western, where he's trained more than 50 graduate students, 30 of whom, or more than 30 of whom, are women, representing 12 countries across 4 different continents. Dr. Luginaah's research spans 2 continents. In North America, his work has uncovered how equity-deserving populations disproportionately experience the impact of environmental issues. In Africa, Dr. Luginaah studies the effect of health inequities, HIV, food insecurity, and climate change. Findings from his research have influenced healthcare reform in the US and Canada and informed decision-making about the risks and impact of air pollution in North America. His research has been recognized with several prizes and awards, including being a Fellow of the Royal Society of Canada, a Fellow of the African Academy of Sciences, and a recipient of the Julian M. Scheitz Award from the Canadian Association of Geographers. Today, Dr. Luginaah will speak on the structural violence that leads to the HIV vulnerabilities of systematically marginalized group in Canada, and about both the challenges and the opportunities that we have in achieving equity, diversity, and inclusivity in HIV and AIDS research. Please help me in welcoming Dr. Luginaah to the stage.
That was nice. Okay, thank you, Jessica, for this very nice introduction. And I should warn you, my presentation is very long. So if I'm skipping slides, that's the main reason, because I was too ambitious, maybe. One thing I would say is that I went to the poster session, and then I was also listening to Jonathan very carefully. It is amazing how much progress has been made on HIV work, no doubt about it. I should also say that anybody in this room, I acknowledge you, because in my view, HIV work is inherently altruistic and empathetic. So if you're already doing that work, you're doing a great job. The problem is, we just listened to Canada's contribution to HIV work globally. But the problem is that within Canada itself, sorry, I already skipped a number of slides. I have a land acknowledgement I think I will skip. I'm already moving on. The problem is that in Canada, we know that although there's progress, we also have a lot of underlying inequities, which is what I'm going to allude to. So while acknowledging the great progress we've made, in fact, when I was younger, I should say, anytime I talked about HIV in my class, you see me tearing, and some of the students would be tearing. It was so bad. We started our early work in Nyanza province in Kenya. Things have changed. And within Canada, we know that the rates are going down, right? And yet, we do have underlying issues with various groups, especially indigenous and black communities. How come that the rates are going down, treatment is improving, and yet we do have pockets of inequities among these groups? That's the question. So I keep going back to the fact that, yes, we acknowledge the progress that has been made, but it seems like the progress has been made for some groups, but not everybody else. Some groups have improved, no doubt about it. Rates are going down, no doubt about it. But unfortunately for my own group and indigenous groups in Canada, it's not the same. That's all I'm trying to say today. So what is going on, right? The problem is that the race and equity data sets have not been very well established in the country. The Public Health Agency of Canada itself acknowledges that it's poorly collected, right? For most cases, we don't have enough race and equity data sets. And so when we don't have the data sets, we will continue to acknowledge or ignore the disparities. For instance, we know and others acknowledge that in the report by the on sexual transmitted and blood-borne infectious diseases, the government never mentioned about black issues at all, even though we know that new cases of HIV every year in the black populations are almost always higher and among indigenous populations. And here I'm saying that the silence simply eliminates the whole idea of do something about it. If you don't know, then there's nothing wrong. You are not guilty. That's my assumption. The only reason why we can't do it, we don't want to do it, is because we want to keep the silence. We can collect that data on the spot, easily. So if it is not collected, it's deliberate. I'm acknowledging everybody here, but I'm also trying to say that it's just not right. That the disparity, we know that there's a huge decline, we know there's improvement, and yet some groups are still languishing with higher rates. It can't be like that. That is why we talk about the prominent responses in Canadian context on how do we move this a little bit forward, right? If the federal government is that silent, and then we don't have the numbers, and then we don't do anything about it, what is the equity here? What is the fairness? So we say that in short, it's left, there is no question for people like us to continue to complain that underlying all of these are structural racism issues. Because we know that Canada has the capability to do it. We know that public health organizations have the capability to do it. And if it is not being done, we think it's deliberate, right? So I acknowledge everybody here, but I'm also saying that we are conscious about the fact that I can do it in my lab if I'm given the opportunity. Why can't the government do it? Or why can't we all collectively do it? Indigenous groups, black groups, right? So it has left these groups with what we refer to here as issuing stigma and the constant thinking that there's that amount of discrimination within these groups, right? So therefore, there are numerous challenges, especially in the black communities with HIV issues. Treatment is improving, and yet our numbers are going up. So how do we deal with it? We are suggesting that I know equity, diversity, and inclusivity for some of us have become buzzwords and are getting a little bit boring. But yes, we are thinking of how do we improve the real issues within groups in Canada without thinking about other ways of, doing our programming. So here we talk about equity, diversity in HIV research. The principles and priorities. Who identified and determines the research priorities? We are in this group. Who identify and determine the research priorities? So we are saying that within indigenous and black communities, HIV rates are still going up or high. They are not going down. Who is determining the priorities? Who has access to evidence that determines that can be used for resource distribution? Is it me? Is it you? Right? And who has access to decision making? So the premise of what I am whining about, if we call it whining, is that rates are going down in Canada for the past decades. No doubt about it. Treatments have improved. We just heard Jonathan's talk, and globally. And in my own university, Eric R's lab, everybody's working so hard. No doubt about it. How come that our groups, indigenous groups, black groups, are having high rates within this country? So that's why we are saying that who has access to decision making? If you talk about methods, theory and methods, what are the relevant methodologies you have to use, inclusive methodologies? How do we do HIV programming in the communities? How do we do it within groups? What are the research goals and objectives? Are we here for academic papers in Nature and the rest? Or are we here for the people? What are the priorities? What are the research questions that we ask? And do these include the ED conceptions, which is the question that we are talking about today, right? In terms of processes, who is engaged? When and how? If we know that indigenous and black communities are now bearing the brunt of HIV in Canada, how do we engage them? Who is engaged? How are affected communities? How are the people who live with these priorities, how do we engage them in HIV work? And how meaningful are the engagements? Are they real engagements? So it's important for public health researchers and practitioners to employ strategies that at least recognizes that equity in health is not that equitable within the Canadian context when it comes to HIV work. So I'm going to describe a study we did that we implemented known as We Speak, and it's not by far the gold standard, but just to indicate that, yeah, you can at least try to engage community in a number of ways. And this was done with a lot of participants, partners and collaborators within the communities. I can't go through all of them. And We Speak emerged out of an earlier study that was led by Dr. Winston Husbands and others called I Speak. And we literally continued with some of the successes they had within the I Speak project. And very briefly, We Speak was funded by the Ontario HIV Treatment Network, thumbs up, and the CAHR. And the whole idea was to understand the vulnerabilities of HIV/AIDS among heterosexual black men. Moving fast forward, this was a call by the CIHR and OTN focused on boys. It was a special call on boys and men's health. So while our project focused on heterosexual black men, there was another project focused on gay men. So I'm just trying to put this because frequently people will ask, why heterosexual black men only? There was another project focused on gay men. So in terms of our project, we had an explicit foundation of the underpinnings were to have principles of social justice at least, equity, commitment towards collaborative work within the communities. We had a very strong, relevant research team, very collaborative. 30 academic and knowledge users came together, as you saw in the previous slide. We had structured, meaningful engagement with our communities. So we made sure that this was done with community partners. A number of innovative strategies, building and empowering relationships with local practitioners and collaborators. We tried very hard from the beginning to recognize the strengths and the resources that people had, and what each of us can bring to the table. We had using communication strategies that can cater for all of our collaborating partners. Tapping into local resources, we know that the local people in the communities are more knowledgeable than we are most of the time when it comes to disease itself, right? So we wanted to make sure that our community partners are well engaged. Engaging in local partnership beyond health sector. We all know the talk about words like intersectionality, going beyond the anti-black discourses for HIV to talk about other issues, including masculinity and the way they operate within their communities. Some of the identities, social identities that emerge, you can see from the racial identities, masculinity issues, sexual identities, class-based issues. I'm moving forward. And we had determinants of heterosexual black men vulnerabilities. Of course, you cannot, I was just mentioning to it, you can't talk about HIV vulnerability among black men, and it has all to do with issues related to racialized issues. And along the line, I'm going to talk about some of the findings in the work we did. So we had, our methods were various methods, survey, focus groups, concept mapping, and moving. And of course, the underlying theories, intersectionality, I'm not going to bore you with that one. And then we also use theories like critical race theory, how society itself acknowledges race issues, and how race issues definitely inform the way we do stuff. And recruitment strategies, given that going to communities to do HIV work, you all know, is challenging. We had project staff from ACB communities. We visited ACB spaces to find the people where they are, like black-owned businesses, barbershops. We went through various stages in order to access the people. Some of the findings, and from that I'll move to the EDID issues. Yeah, ACB experienced difficulties accessing HIV resources and feel that current programs have limited options for them. We found that 67% of the participants felt that they were treated with less courtesy when they went to seek services. 67, with less courtesy when they went to seek services. Being immigrant, we know, is already a challenging issue, and then we found that those who were immigrants were less likely to feel that they had proper services. And of course, religion, Muslim, different groups, young men, they were all reporting that they had challenges accessing services. So, here comes the argument about EDID. If 67% of our clients think that they didn't feel that they were well treated, what was the problem? That is why we are alluding that maybe consciously, if we start to think about some of the challenges, it may help. It may help. So that is why we are talking about equity, diversity, and inclusion here. Public health is faced with an important challenge on how to effectively achieve aspirational goals for everybody. For everybody. Again, this is on the basis of the fact that in Canada, HIV rates are going down. No doubt about it. We are all happy about that. But how come that we have pockets that are not going down? That is why we say we have a challenge if we really want to do a good job. I argue that in the context of public health, HIV research will benefit from being conscious about these issues, from being conscious. Probably for those of you who are working in places like Africa, obviously, yes. But within the Canadian context, we cannot assume that the rates are going down and yet we have pockets that are not doing very well. I will comment on a few issues I believe will further this effort and then conclude with some recommendations. Equity, we all know, like I said, is now a buzzword. What is equity? It's based on the notion that existing disparities are rooted in some form of historical or underlying challenges that we have to deal with, right? Moving. Diversity, we all know. What is it? A diverse, inclusive organization would include programming for people with different opinions, backgrounds, religious beliefs, political beliefs, and we all probably heard this already. And then we talk about intersectionality, which is, if you talk about diversity, then you have to acknowledge intersectional issues. Intersectionality, this perspective we all would have heard several times, especially in HIV work, deals with how power structures and everything else, you acknowledge power structures and differences within groups. I am moving. So in terms of diversity, there are some issues. The privileging of some groups may effectively sideline other groups. Social justice issues and rationales for diversity. If you privilege some groups, you sideline others. That is, numbers may not necessarily always mean diversity. I joked in my university, if there's any Western person here, they should keep quiet. When I first arrived at Western, in my whole faculty, I was probably the only black guy. So I called it the solo effect, where you have to literally smile all the time because I'm the only black guy. I can't afford to be angry. That's tough, right? But there was a black guy. I'm making a joke. Don't quote me outside of here. So if you put one person in the group, that doesn't mean you are diverse. Sorry, but it's happening in many departments, right? For instance, there's persistent underrepresentation of indigenous people, women, minorities, black people in various areas. And once we get one, like me, then you feel that you are diverse. That's not the case. Inclusion, which we also know, primary aim of inclusion is to leverage the cultural capital. The cultural capital, and in HIV work. I said in those days, the beginning, the misunderstanding of culture was one, everybody who does HIV work know that, was one of the things that led HIV out of hand, especially in sub-Saharan Africa. You need to have to understand the cultural capital, right? In public health, inclusivity will result in an environment where everybody feels welcome. Here's a quote from the work we did. I went there and, sorry. I should go back if I can. I went there and had an issue. This is a participant commenting, and had an issue with these folks. I asked that I be referred to another clinic, and they said, no, I'm summarizing because I'm looking at my time. And they said, no. They rather send me to somewhere else and ask me to go there for treatment. This was an HIV person talking. In other words, this is in Canada. This work was done in Canada. In other words, there's something wrong, right? HIV researchers who adapt and engage inclusive efforts ensure that all marginalized groups are welcome. All marginalized groups are welcome. It is important to know that while inclusivity encompasses diversity, the reverse is not always the case. A diverse group is not always inclusive. Having a few diverse groups in the park does not necessarily mean they are welcome. I won't talk very much, right? It doesn't always mean they are welcome. Yeah. Inclusion is the deliberate act of welcoming diversity. It's a deliberate act. And you cannot eradicate HIV in some of these groups without making people feel included or belonging, which is what I'm going to, right? Do I really belong here for HIV care and treatment? We already know the HIV, what it is, right? Already you are emotional hit. What else can turn you off when you feel you don't belong here? You're already suffering emotionally. So do I really belong here? If you want to go to a HIV program or where the service provision, you want to go where the services are, you must feel that you belong. Otherwise, it's challenging, right? So we say that inclusion is the core of diversity, and then equity and diversity without inclusion is zero, right? Equity and diversity without inclusion does not work, right? On the other hand, excluding equity in the mix would reinforce the status quo. And what is the status quo? We know. I'm not going to talk about it. It will exclude the status quo. In contrast, equity and inclusion without diversity may miss the wisdom of the Krauss exploit, which all of you probably know. And in HIV work, in the communities, if we go with the status quo, which is probably why our indigenous populations and black populations are recording the highest, something is not right. I don't know what it is. We are probably going with the status quo, right? Addressing EDI issues, improving outcomes through meaningful community engagement, equitable cross-cultural and racial understanding is needed somewhat. If the numbers are going up, we are doing something wrong, or we are not doing something right. It's that simple, right? Expanding worldviews through inclusion, where service providers have the opportunity to interact with people from diverse groups, so that the person who says, I went there and didn't feel I belong there, and didn't feel welcome, they should feel welcome. It's HIV. I'm already emotionally tortured. I don't want any extra snob. That's not right, right? A few quotes from a young man. The hardest thing about being black in Canada is the prejudice I feel, and that's where my fear comes from. And then one of my favorite quotes when it comes to equity and diversity in Canada, from Justice Rosalie Abel in 1984, great quote. Ignoring difference and refusing to accommodate them is a denial of equal access and an opportunity. Is discrimination. This is from a chief justice, right? To reduce discrimination, we must create and maintain barrier-free environments so that individuals can have genuine access to free from arbitrary obstructions to demonstrate and exercise fully their potential. Basically summarizes all what I'm trying to say here, right? Some challenges, yes, I know. What are the conditions required for us to really see any transformation in public health, institutional culture? Is there something wrong with it? Well, we can say no, but I'm saying yes because black and indigenous populations are not seeing the same declines as white populations in Canada. So there's something wrong. There's definitely something wrong, right? How do we collectively shift the deep-seated values and assumptions that underlie the daily operations in public health? If rates are going down over the last 2 decades and some people are not experiencing benefits, there's something wrong. It's that simple. How do we collectively transform the reality whereby racial ethnic groups seeking health HIV care will continue to feel like they are not guests in somebody else's house? If the gentleman walks in there and feels that they were not welcome, they won't show up. And their stories will prevent others from even attempting to show up. I'm guessing somebody else's house. Right. One of the issues that frequently show up, not only in HIV work, in all of our daily lives, is unconscious biases. I think the services are there. I think the treatments are there. I think the programs are there, and I think the academic research and the knowledge base is there. So why is everybody not seeing the same benefits? And one of the challenges is unconscious bias. And yes, unconscious bias in hiring, in recruiting, in funding is all over the place. And yes, we all do have unconscious bias, all of us. We all have unconscious bias. Right? The inclination and attitudes and stereotypes that we have without knowing. We know that one's unconscious bias always tend to be favorable towards what you feel comfortable with or what you already know, or similar characteristics or similar circumstances. Right? Whether unconscious biases are obvious or subtle, it can create a ripple effect without you knowing. It can create a ripple effect. That is, small decisions become big decisions. Just that not giving that guy that courtesy or, oh, you are welcome, it's a huge deal. With HIV, I keep referring to it, somebody who's already emotionally hit. Right? What can we do? Challenging the myth of unconscious bias. Even individuals who strongly feel egalitarian may still rely on problematic schemas, all of us. I started by acknowledging that I think every person involved in HIV work is immediately altruistic, empathetic, and all of those words. It's a tough area of work. But we are saying that even with that, even though we feel that we are doing all this work, we still have underlying problematic schemas. Confidence in your own fairness may prevent you from being as fair as you can be, including all of us. If we already think, oh, I'm the one doing all this work, I'm helping in the community, and you are not careful, then you miss the point, right? For example, if you think you are always fair, then others are always wrong, or they are weak, poor in judgment. I'm relating this to the service provision. The work we did was related mostly to service provision, and it was just a little bit disturbing to read. If, going forward, in collaboration with community members, the National HIV Surveillance System has established a black working expert group, and I think that's encouraging. We need to find a way to get into these communities and also our indigenous groups, right? CAHR, in collaboration with the data contributors and data users, has to make sure that we have the right data set so that we can identify where the problems are. I had moved very fast because I want to get to the end of my presentation. One of the things is that from the last 2021 report, only 45.3% of race-based data was collected. And in provinces like Manitoba and Quebec, zero race-based data, which is why I tend to comment that is it urgent towards being deliberate? You need race-based data. If you have a simple paper, everybody, did you control for race? Did you control for this? How come that we can't establish these numbers and use them for simple programming, right? It's encouraging that this is acknowledged. It's encouraging that this is acknowledged. PR's engagement with diversity policy is necessary. It is very necessary. Again, acknowledge, we have to recognize that we cannot, HIV will not go down to where we all want it if we have some groups being left out, right? If we have some groups being left out. There's a need for involving equity-seeking groups. The problem is that's where we started. You cannot reduce HIV, as we know that all of us in the field, you can't reduce HIV in indigenous and black populations without having those groups really engage at all levels. At all levels. Ending transmission in black communities requires transformative response. Require transformative response. People must feel belonging in one way or the other, right? There's a need for inclusive, innovative interventions that effectively disrupt that systematic kind of anti-black feeling that has been put in us, right? Need to address those feelings. The people who are having the HIV more must feel that there's help for them. Black communities must be involved in some form of leadership. I'm not saying they should be the Minister of Health, but in some form of leadership to engage themselves, the same with indigenous communities. They must be involved much more than they are if we want to have the rates down, right? We all know that, especially among gay men, they were really involved right from the beginning. If you were not aware, go and watch the old, one of my favorite movies I show in class is called And the Band Played On, to see the effectiveness of mobilization and different groups. That was done by Richard Gere quite a long time ago. I still show it in class to teach my students about disease transmission and how politics, especially what we are talking about, how politics can dwarf public health in some ways. One of my good friends, Katrina Plamondon, and her group did a paper on turning on equity and how systematic equity-based analysis can be used if we are talking about equity in HIV work. I am not going to go into detail if you are really curious. They write a lot about, as part of the Canadian Coalition of Global Health Research, they have the global health principle, really nice, which can be adapted even within HIV work in Canada. And they wrote this paper with a framework about equity and action analysis. The paper was published in 2003 in BMC Public Health. Plamondon, Katrina, is in UBC with some group. If you are curious to read about all of the frameworks that could be used, go look for it. My conclusion remarks, the promotion of EDI is critical in harnessing the full range of human creativity, community support, and the talent necessary to realize HIV programming in the Canadian context. Strong and positive institutional cultures and climates are essential to achieving public health goals. EDI must be demonstrated not only on paper. We all know the buzzwords now. Huh? We all know the buzzwords, to the point that, like I said, it's actually getting boring, right? Everywhere. The other day, again, Western folks, sorry, I had to give a talk somewhere, and I found that in Western, almost every department, every faculty have their own EDI statement. I said, what a joke. We have more than 13 documents. Oh, come on. Right? We know what it is. We don't need tons of documentation. We all know. If we want to do the right thing, we know. Right? It must be demonstrated not only on paper, but on reality. Innovative and inclusive engagement strategies underpinned by the principles of social justice and equity. The Plamondon paper, if you want to read it, you can read it. Collective self-determination, Black and indigenous groups, and the capacity of building critical and mobilizing Black racialized communities to develop effective responses. We cannot not afford to engage these communities if their rates are so high compared to others, if we want to have the rates down. To make effective change, public health should increase at all levels the number of previously excluded underrepresented equity-seeking groups, women, people, racialized minorities, LGBTQ people, indigenous communities, students, whoever, right? What needs to be done is to include explicit voices. We have to include these voices. We can't exclude them from underrepresented groups. And my favorite quote from Maya Angelou. Maya Angelou says, I have learned that people will forget what you said. I'm sure after I leave this podium, nobody will remember what I said. People will forget what you did, but people will never forget how you made them feel. And in the context of HIV work, seeking care, I'm talking out of the fact that the program we did, I was probably moving fast, it just came out over and over and over again, how the black community had these challenges of seeking HIV services, over and over. And there were all these quotations about the discrimination, the going into the service provision and feeling not wanted and not going back. And it was just way too much, way too much. Why? Because of how you made them feel, right? Whatever you said, whatever you did, the worst thing is how they feel. And as I said, this is a group that is already emotional hit. We know that. We know that. So if you've already tortured emotional and you walk in there and you don't feel welcome, how do you feel? And that was the end of my talk.
Thank you so much for that incredible talk, Dr. Luginaah. Do we have any questions? We have a little bit of time for some questions. Everyone's shy this morning. That's okay. Oh.
Not everyone is shy this morning. Good morning, everyone. Bonjour tout le monde. My name is Tammy Yates Rajaduri. My pronouns are she and her. Dr. Luginaah, I hope I'm pronouncing your name correctly. Congrats. Thank you so much for that presentation. And kudos to the CAHR board, the scientific committee for having this presentation. The number of years that I've been coming to CAHR, and this is the first time that we're having such a presentation, and in a plenary. So again, kudos. Congrats again on the work that you are doing. We're very much aware of how critical this is for equity-seeking groups. So my contribution this morning is a comment, is a call to action, and a shameless plug. So as the executive director of Realize, and you spoke about realizing education and HIV research and so on for equity-seeking groups, one of the things that we feel very strongly about, because we hear from the community of people living with disabilities and the deaf community, and these are equity-seeking groups within that framework of EDI that is often not part of the EDI. So within our work at Realize, we use what we call the ideal principles: inclusion, diversity, equity, and accessibility leading to belonging, because that A is often what is left out. And among equity-seeking groups, people with disabilities and the deaf community is often the margin of the margins. So my comment is, well, that's the comment actually. My call to action is for all of us to ensure within whether your EDI work, whether your ideal work, that around accessibility, because from an intersectional perspective, all of the equity-seeking groups are also comprised of people living with disabilities or the deaf community. So the call to action is to ensure that that A is front and center as well. And then my shameless plug is for everyone to join us at the Realize booth, where we're sharing our information on this work that we're doing and launching our podcast, which focuses on this work as well, this evening at 7 o'clock. So thank you very much. Continue the great work that you are doing. Believe me, I have walked in your shoes, Dr. Luginaah, as a Black woman, as an immigrant to Canada, within this movement. So I hear you, I see you, I appreciate you. Please continue the great work. And again, the call to action is for everyone to ensure that you are applying your principles in each of the corners and the spheres that you come from. Thank you very much.
Hi, my name is Marvelous Mchenje. I'm the Community Relations Manager at Viviot K Canada. Thank you so much for the presentation. And I think for most of us, this is not the first time we're hearing it. And we always hear it and hear it. But for how long are we going to hear it? And my issue is sometimes we preach to the converted. It's us who are familiar with the challenges. And the main reason why people, Black people and indigenous people and other marginalized populations are still being left behind is because of the other social determinants of health. Some things that maybe we are not incorporating in our HIV work, and because we don't just live in AIDS-safe organizations or just go to the HIV clinic, we go to the dentist, and sometimes we go there and we are discriminated. We go for housing and we are discriminated. And I've worked so much with women, and I found that HIV is the last thing on their brain, and their health is the last. What comes first is their children. Are their children in school? So how best can we work as a community to bring also other allied health services, but also other organizations that cater to the health and the quality of life of people living with HIV, to make sure that, yes, then HIV becomes their priority. So when they're working, yes, they feel discriminated, but they are also being discriminated in major hospitals where you think people know about universal precautions, and you're seeing people wearing 3-4 gloves when they look at you, and they're asking you, why are you here? Why are you in Canada as a Black person? So I think, how do we move that knowledge to action in the research that we are doing? How do we invest in making sure that the quality of life, we are looking at a person as a whole, but not only their HIV?
That is a very, very good comment, and a complex one, right? So I alluded to the notion of the intersectional issues we confront. And I think that from starting small from somewhere is always good. If public health will come down to start to engage with communities, they will know the other problems as well, right? I hear you. It's very intersectional. It's very complicated. But what we can do, at least for HIV work, is the work we do, we should at least make sure we're doing what I would say the right thing. At least that's what we are committed to. And I like your comment about preaching to the converted, which is why I keep saying I already appreciate everybody here, unfortunately. But I'm also hoping probably there's a policymaker who, for some reason, is here who can do something else, right? But that is always the danger. You end up preaching to your colleagues who are already all in the field struggling with the same questions. But this is the Canadian HIV is a biggest conference. So I'm hoping some of the information will slip out of this building to somebody else, right? But you're perfectly right. We are confronting intersectional issues, several social determinants. The discrimination, the work we did is all over the place. That's what I was saying, right? My time is up. Thank you.
Thank you so much.
Oh, yeah, thank you. I hope it.
Yes, yeah, thank you so much again, Dr. Luginaah. So this is going to close out the plenary sessions for this morning. We're going to start the concurrent oral abstract sessions promptly at 11 o'clock. And so we have a little break until then. Thank you very much this morning to all the speakers.